critical care with it because we talk about drownings and poisonings and, PALS and things like that. But this is the hardest to understand of probably everything we're going to talk about in all of pediatrics. So I think if you thought growth and development was hard, so just bear with me. We'll get through it, but really pay attention when I say this is going to be on the exam. Really circle that because it'll be there, okay? So I'm going to help you get through peds cardiac. All right. So we have to, as nurses, understand how the heart works, okay? Every single patient I take care of, it's important that I'm understanding what their cardiac status is, right? So we've got to understand what the body's doing, okay? So it's so simple that we think about, blood goes into the lungs, it gets oxygenated, it gets pumped into the body, but it's more complicated than that, isn't it? Right? So we should all know this already, right? Systemic circulation carries oxygen-rich blood. It pumps it through the body, right? Out through the aorta. A heartbeat, right? It's a rhythmic electrical signal, right? Your heart does two things. It's got electrical current and it's a pump, okay? So the electrical current is that electrical impulse. Contracts the atrius first and then goes down to the ventricles, okay? Heart rates in children differ than adults. But what you'll find is that infants and toddlers are higher, and then children equate more to a normal adult range, right? So we have to know that if we're working in pediatrics. We have to know what a normal heartbeat is, right? We also have to understand that blood transports nutrients for cells and energy, for waste removal, to keep our body clean and functioning properly, right? It also helps regulate body temperature. And in children, this is an important thing to remember because you're going to find a lot of these cardiac defects with children. They also have trouble maintaining their body temperature, okay? Heart valves, we've got 4. There's a couple things that can go wrong with children with their heart valves, okay? We'll talk about those as well. And then understand that the heart has 3 layers. The epicardium, the myocardium, and the endocardium. And you can get infection in any one of those, right? It's called epicarditis, myocarditis, endocarditis, right? Not a good place to get an infection, right? So the heart is really important. It coordinates all the living functions of our body, right? And so imagine now you have a baby whose heart would fit in your hand, right? A newborn, okay? So what are some of the differences between when a baby's born to us today, right? So first off, we've talked about heart rate, blood pressure. What are some of the things you've noticed about kids and blood pressures?
Super low.
Lower, right? Like an infant, 80/40 is normal. If you got that in your adult, you'd be like, I don't like that, right? So they're lower. They increase over time with age and development. The location of the heart when babies are born is born more over here and rotates into the left side. The ventricle walls are thicker. And the right ventricle dominates at birth and switches. So everything's a little different, right? A lot smaller, but different. Common medical treatments that we do, a lot of it's medication, isn't it? A lot of medication we give for cardiac problems. Oxygen's one of the biggest ones. We've already just talked about the heart's responsibility for supplying oxygen through the body. So when you're having a cardiac problem, what's one of the first things we do? We give you oxygen to help you, right? Support the circulatory system and the heart. We might do chest physiotherapy or postural drainage to help maximize secretions. You might need a chest tube with surgery. And then pacing. What do we pace?
The heart.
Well, heart rhythms, right? We pace rhythms. And we normally pace rhythms that are what? Too slow, right? Mm-hmm. So if we've got so I was working Friday and I see from triage, they come running in with this guy on a stretcher and a life pack and it's all exciting, and on the way back I said, so what was that? And they're like, heart rate of 30. Well, what's that?
Not good.
Well, not good. Bradycardia. Complete heart block is what that is, right? So we know that the atrium and the ventricles are beating all erratically and not good, right? So 30 is too low for a heart to be effectively beating. So we pace that rhythm up, okay?
So that means like the bundle of his is taking over?
Yeah, he's having a lot of problems. His heart is just blocked. Yes?
So we don't have these PowerPoints.
Nope, you
So
don't.
you can't post them for us. So
No,
they can-
I will, but did you hear what I said at the beginning?
I did, but I didn't.
It's not
know it
finished
was
yet.
Oh, okay.
So I'm
we have
lecturing
some.
from 2 PowerPoints today.
Okay, so,
So
the
just
whole
hold
first
on.
part is
Yeah,
like not-
yeah.
Oh my goodness.
Just
Okay.
hold on. I've already done it and we made it, so it's fine. Okay? So you will get this and you'll have it, just not for my lecture. Because I had to take care of me. Sorry, I needed a
No,
self-care weekend.
I understand. I just wanted to make sure that.
I just couldn't get it done. So I can lecture from my other lecture, but this is much better. So just bear with me.
That's fine.
So these are the common medications that you will give as nurses for cardiac issues, right? So you'll see a few up here that you're like, prostaglandin, indomethacin. I've never seen those used before. Hold on, those we use with kids, okay? But a lot of these you've seen, right? Propranolol, captopril, antihypertensives. We give a lot of those medications. Metoprolol, lisinopril, right? Cardiac cath. You guys just went through learning about cardiac caths. We do them for children too. Often with kids born with congenital heart defects, we do a cath to really diagnose and to see what's going on in the heart, okay? We go in the same vessels that you do in an adult. The post-op care and treatment is the same. So I'm not going to belabor heart caths with you guys because you've already had it, okay? These are the congenital heart defects that we're going to go over this morning. Hi.
We had to.
Oh, hi. So these are what we're going to go over today. And then at the end of lecture, we're going to do an activity. All right? So, congenital heart defects are more common than you would think. More than 1% of all newborns have some sort of a defect. Now, it doesn't mean they've got like tetralogy of Fallot or some massive major defect, but they might have a little hole in their heart, like an atrial septal defect or a ventricular septal defect. So we see them quite regularly. A third of those with these defects result in death or require cardiac surgery. So some of them are born with things that are incompatible with life, and I'll teach you about that one too, okay? But the majority of them do fine, but they do require some interventions, okay? So one thing I want you to pay attention to is you'll see a lot of things that are similar. Start finding the similarities, okay? So like on clinical manifestations, they're almost all the same with heart defects. Okay? So try to make it easy for yourself when you're thinking of things. So comorbidities, what do I mean by that? Kids with Down syndrome have a higher incidence of congenital heart defects than those without. So comorbidities, a neurodevelopmental disability also has a CHD. Okay? All right, so we're going to break these down based on what is happening, to try to understand it a little better, all right? So they've made it somewhat easy, so if you follow what it's describing, decreased pulmonary blood flow. What's that sound like to you? Somehow it's obstructing getting it into the lungs somehow, right? So now not enough blood is getting into the lungs to be oxygenated to get out to the body. Make sense?
So
Okay, so is that person going to be cyanotic or acyanotic?
cyanotic?
Cyanotic. Are they going to, what are they going to look like besides purple? Are they going to be short of breath? Are they going to be tachycardic or not?
Tachycardic.
Yes, okay? So follow that thought with me because you're going to need to stay in that higher brow thinking to get through these lectures, okay? So decreased pulmonary blood flow. You've got an obstruction in the blood flow to the lungs resulting from this obstruction. Pressure in the right side of the heart goes up and becomes greater than that on the left side of the heart, okay? So then blood from the higher pressure shunts over to the left side in that structural defect, okay? So these are going to have mild to severe oxygen desats. These are cyanotic kids. These are kids that have spells of cyanosis called hypercyanotic spells. that if you don't intervene, that kid can die. What have I taught you about NCLEX and PEDS? You got to know things that are going to cause a kid to die if you don't intervene. You think that's going to be on there? 100%, okay? So what happens then? The body is living in this kind of decreased hypoxic state. Average pulse ox are 50 to 90, okay? So the body starts going, wait a minute, we need more oxygen. We are oxygen deprived down here. I know what I can do. The kidneys are gonna come and help. We're gonna save the day. We're gonna produce this protein, hormone, called erythropoietin, to stimulate the bone marrow to send in a whole bunch more red blood cells. Because we're gonna save the day and create more oxygen. But it's a fake. It fakes it out. It really doesn't do anything, okay? It just increases the workload of the heart, okay? So the kidneys think they're helping, but they're really not, okay? The two big ones for this are tricuspid atresia and trichology of Fallot. With TET, you have 4 defects. You have pulmonary stenosis, so you've got narrowing of the pulmonary valve. You've got a ventricular septal defect, so you've got a hole in your ventricles. That's not supposed to be there, right? You're supposed to have a septum between your ventricles. You're going to have an overriding aorta here. And then you're going to have a right ventricular hypertrophy. You see the right ventricle over there? Okay? And that's from all those high pressures we told you were in the right side of the heart. Okay? The right ventricle just goes, oh my God, I'm so tired. It's like blowing up a balloon, right? Those constant pressures. So, usually diagnosed pretty quickly after birth. You guys remember your fetal circulation? I'll bring you back to it. Oxygenation is through the placenta. The lungs are perfused but do not perform oxygen and ventilation. You have a ductus arteriosus. Sound familiar from Professor Horn? That allows blood to flow between the pulmonary artery and the aorta. And a foramen ovale, opening between, right? What happens when the baby breathes?
You mean once it's born?
Yeah.
Closes.
Closes. So what do you think happens to this guy then? Right?
Doesn't close?
They're born with the PDA, which increases the pulmonary blood flow. But as soon as that closes in the first few days of life, they have severe cyanotic spells. So if you don't know this baby has TET, they're in your nursery, and you go to bring the baby in, and they're purple, okay? So clinical manifestations, severe hypoxia, okay? Hypercyanotic spells. They have the clubbing from the chronic low oxygen. They're short of breath. They get agitated. I get agitated when I can't breathe. Just think about it, right? Irritable. Poor feeding. I'm going to say that every single thing I go across is one of the first signs of congenital heart defects in babies. Think about it. What is feeding a baby do? It's a stress test for a newborn. Okay? Their heart rate goes up, they breathe a little faster, all their vitals go up. It's a stress test. It takes 20 minutes of sucking on a bottle or a breast to get a feeding, right? Well, that 20 minutes will wipe out a kid with CHD. They will be sweaty, exhausted, okay, and probably eat an ounce in that same time period because they're working to breathe. They're like, okay? So remember poor feeding and consequently poor weight gain, right? So TET spell treatment will 100% be on the exam and it will be on your NCLEX, okay? So what do we do when somebody has a hypercyanotic spell?
Oxygen.
There are 3 things you do, and you gotta know, or 4. I'm gonna write them down so we don't get them wrong, because you're gonna see them on the SATA. So when you walk into a room and a kid's having a hypercyanotic spell, if it's an infant, you do knee chest. If it's a toddler, they squat. What do you think that does? Why do you think the cyanosis stops? Well, we're increasing systemic vascular resistance, right? I don't have to now perfuse the down here, and I'm increasing my pressures. Okay?
Basically putting them into
So
parasympathetic.
yes. All right. So oxygen, morphine, remain calm, and do the knee chest position. And then they go in for surgical repair between 2 to 6 months of age. This is a major, major defect. You got to know about trichology of flow. Okay? So here you go. You got right ventricular hypertrophy. Ew, I can't push it through despite my even though the muscle looks like it's super developed and it should just be able to push it through, it can't, okay? The right ventricular outflow tract obstruction, okay? So you got the hypoxia, hypoxemia, the boot-shaped heart on the x-ray, your VSD. Get us oxygen, we're turning blue, the 4 fatal 4s of flow. All right? Nurse has a patient with a TET spell, what do?
A, C, and E.
Right.
ACE.
Tricuspid atresia, another bad one, okay? This is another pulmonary obstruction, so they have decreased blood flow, so it's another cyanotic defect. I'm still in those 2 hypercyanotic defects. So the valve between the right atrium and the right ventricle fails to develop, okay? So there's just no valve there. So there is no opening to allow blood flow from the right atrium to the right ventricle and subsequently out the pulmonary artery to the lungs. So again, they're cyanotic. They're not getting oxygen to the blood. So they're short of breath. They don't feed well. They've got fluid in their lungs. They look like somebody who's in what? Heart failure, right? That sounds like a heart failure patient. Cyanotic, tachypnea, not eating well, crackles like dyspnea on exertion, murmur. Murmurs, almost every cardiac defect we talk about today will have a murmur, okay? You don't have to know murmurs for this exam, okay? I don't know all the murmurs because they're all different locations. Like you can look for a systolic ejection murmur on the second, rib on the right. Like you don't need to know that, okay? So these guys get early surgery and diuretics. Prostaglandin helps increase the oxygen for a while. And then just understand that every kid who's having cardiac surgery will go on antibiotics, need pain control, gets a cardiac cath as part of diagnosis and needs a lot of nutritional support. I'm going to talk about congenital heart defect, general management, but nutrition you will see us spend a lot of time in. Remember, we're talking about predominantly infants and toddlers right now, where growth and development and nutrition is at its critical time. And so if you think of a kid who gets tired with eating, how are you going to get them the nutritional support? We have to supplement. So if they're breastfed, we might have to give them extra calories. If they're bottle fed, we give them high calorie formula, but we don't let them work at it for 45 minutes to an hour. We cut it off at 20 minutes.
So like frequent small.
Mm-hmm. Yep, because we don't want, because remember I said a feeding for an infant is a stress test. So I don't want to stress test my kid all the time, right? So I would do 20 minutes and stop, NG tube the rest of the feeding to supplement, okay? Because they need the calories, they've got to have the extra nutrition and support. So here's tricuspid atresia from your textbook, just so you can see it as well. All right, now we're the opposite. Now we're flooding the lungs with blood, okay? Before, there wasn't enough, and so they were blue, and the body was screaming for oxygen. Now we've got too much blood in the lungs. The lungs are like drowning, and what does that manifest usually? How does that clinically manifest in your patients that you've already taken care of? The lungs are filling with blood. Crackles. What else? Edema, think of heart failure. All of those signs, right? You guys know those signs? When you got too much blood in your lungs, it's just like heart failure.
Pink frothy sputum.
Edema, yep. All right, so remember, these kids will be at increased risk for pulmonary infections because of all that blood sitting in there, okay? It's the same principle as if you had fluid in your lungs from a cold and it sits there and bacteria builds up. Blood does the same thing, okay? So oxygen isn't always helpful because it acts as a pulmonary dilator. And we've already had too much blood in there. Okay, so really start to try to understand some of these concepts. The diseases themselves will make a lot more sense if you can understand the concept, okay? Atrial septal defect. These two or three are pretty easy, okay? You just got a hole between your atria. If it's small, it's probably asymptomatic and you can live with that the rest of your life. If it's large, you're probably going to have symptoms and probably need to have it repaired if it doesn't close on its own, okay? And a lot of these will close on their own when they're small, okay? So, a hole in the hole between the two atriums, small. ASCs usually close spontaneously by 18 months. Large require surgery. With most of them, they're asymptomatic, but you may have same types of behaviors. Poor weight gain, delayed growth and development, poor feeding, and a murmur, okay? You see how they're all the same? And then management, you guys will see that echoes and heart caths are diagnostic just like it is with adults, okay? So kids get them just like adults. So an echo, a heart cath for diagnosis, spontaneous closure if it happens, otherwise they go in for surgery after, around age 2, okay? So here's just an example of a little hole that doesn't belong. They're communicating, okay? So blood just kind of goes back and forth. So you have a nurse caring for a 6-month-old who has an ASD. She's asymptomatic. The parents ask, should they anticipate surgery? What would your answer be?
B.
B. Yeah. Yep. All right. A VSD is kind of the same concept, but between the ventricles, okay? So an opening between the left and right chambers of the heart accounts for 30% of all CHD. So VSDs are very common, okay? Spontaneous closure of small ones occur in 50% of children by age 2. Same kind of thing, right? Put them together as you're trying to memorize this and understand it. They may be asymptomatic, just like the hole between the atrium. If it's small, a little blood back and forth probably doesn't matter. Big, you're going to have a problem, right? And have signs of heart failure. And that's going to usually pick up within the first couple weeks of life. Do you see that? Mm-hmm. This kid's all of a sudden, you're going to see a history of poor feedings, delayed, weight gain, and you're like, what's going on? What's happening? And then you're going to start seeing some sweating during feeds, and maybe start seeing even some swelling and some edema. And remember, kids don't have edema unless there's something really wrong, right? And then management for these, spontaneous closure for the small ones, and then large ones require it if by 2 they haven't. Don't forget the importance of preventing long-term, like increased pulmonary flow. Do you know what that results in? Pulmonary hypertension, pulmonary vascular disease, right? So you don't want any of those. Those are bad things. So here's a VSD. You can see there's a hole right here that doesn't belong. So the blood's just kind of communicating back and forth.
What's considered small?
That's a good question for like a cardiac surgeon, but it's usually small. So I don't know what small is by their terms. They don't describe them. And then you can have an atrioventricular septal defect, which is failure of those cardiac endocardial cushions to fuse during embryonic development. And so these account for only 4%, but there's a high association with Down syndrome with this in particular. So again, signs of heart failure for the large ones, smaller ones you may not even notice. increased respiratory infections, poor weight gain, poor feeding, increased work of breathing, and murmurs. You notice how they all have the same signs and symptoms? So I'm probably not going to ask a lot of sign and symptoms questions on the exams.
See, I think you should.
But you think I should? There'll be some, but not a ton because it's all the same signs and symptoms, except those cyanotic ones are they pretty well set themselves out, right? So again, usually done in the first few months of life to avoid developing pulmonary hypertension. They can either go in and surgically sew it together or put a patch over there. And then again, I just put antibiotics and pain relievers because they're important. There you can see the AV canal defect to consider. PDA, what do you guys remember from Professor Horn on your patent ductus arteriosus? What happens? Right? What happens when a baby's born and they take their first breath?
Oh, closes.
Right? We switch, right? And so this duct is supposed to do what? Stay open or go closed?
Closed.
Closed. So what happens if it stays open? Because that's what patent means. Patent means I'm open. It means it stayed open and didn't close when I took that first breath in that first couple days of life, okay? So what happens is you get now communication between the aorta and your pulmonary artery, and so you've got congestion again. You've got too much blood in the lungs, and you're going to have signs of heart failure and your bigger issues, okay? So same kind of symptoms, except this one can send a kid into AFib. And there's very few rhythms that send kids into AFib, but a PDA can. So a lot of times they're asymptomatic and don't need treatment, but you're going to find that the PDA, sometimes we need to keep that duct open. Now you're like, oh crap, I thought you told me it was supposed to close. It is in a normal, healthy heart, right? But if you have an abnormal heart and it's not healthy, sometimes that needs to stay open so you can have any circulation in your heart at all. I lost a few of you. Sometimes when that closes, if I've got a major defect, I won't have blood flow through my heart. So I need this to stay open, okay? I'm going to show you a couple ways where I mean that, okay? So I give you indomethacin if I need to close it because it stayed open. And then sometimes I need it to stay open. So don't get confused yet. It's easy to do in this. All right, coarctation of the aorta. We have obstructive flow. So just think about your aorta and how it sits in your heart. Now you've got like a tourniquet around it. That's the easiest way to remember a coarc. A coarc just means you've got a narrowing or a constriction to a vessel. And so you have a narrowing of your aorta. So all of your pressures are distal to that, right? So now, because of that, you have a problem carrying the oxygenated blood from the left ventricle out to the body. So depending on how tight that tourniquet is and how severely the blood flow is compromised, depends on your symptoms, okay? But you will always have, and this will always be on an exam I give, blood pressures and pulses that are bounding and higher in your upper extremities and weak and absent and lower in your distal. That is often how, as a nurse, you and I can diagnose a baby with coarc right at the bedside. We don't need an echo or anything. If I come back and I've got bounding pulse pressures up here with hypertension and weak absent pulses down here with lower blood pressures, you've got a coarctation, okay? Remember your blood pressures. So here you can see the tiny little coarc right here. So how do you think we fix it?
Stent?
Do you think if I put a balloon in there and blew up the balloon, maybe it would dilate? It works.
And then they put a stent or no?
Yeah. Yep. They can go in with a balloon, dilate it, and stent it. Sometimes, depending on how severely the damage is, they might have to take it out and reanastomose.
Gotcha.
But they can balloon and stent. Yeah.
Would the blood pressure show like different if you took it on the arm versus the leg?
That's what I'm saying.
Yeah.
Your arms are higher than your legs. So you do all four. Okay? So as a nurse, if I'm ruling out co-work, I go in and do blood pressures and pulses on all four extremities. And the arms should be pretty consistent, and your legs should be pretty consistent, and a big difference between the two. Okay? Aortic stenosis, again, obstruction. These are all obstructions, okay? But this is between the left ventricle and the aorta. So this is one of the rare ones that cause chest pain in children, okay? We don't see a lot of chest pain in children, but kids with aortic stenosis can get angina-type chest pain, okay? So fatigue, chest pain, dizziness, difficulty feeding, faint pulses in severe cases. They can have a thrill, and you know thrills you feel, murmurs you auscultate. And then an echo and heart cath are used to diagnose, and then they do balloon or surgical repair. So here, I have a stenotic valve I'll show you later, but here you can see the left ventricle all hypertrophy and everything. It's crazy when you see it. And then you can have stenosis of the pulmonic valve as well. So this is between the right ventricle and the pulmonary arteries. And if this is a small little stenosis, kids are asymptomatic, but if it's big, they have that same fatigue, dizziness, fainting, dyspnea on exertion, a thrill, and a murmur. And they go in and replace the pulmonic valve. Is how they fix it. So there you can see, it's kind of showing you that. All right, mixed defects. I have a few more. So you know how it says mixed? What do you think it means by that?
More than one?
So you got a little blue blood and a little red blood all mixed together. Okay? So these are kids that have some major problems. Transposition of the great vessels is not a good one, right? So now your pulmonary artery and your aorta are flipped, okay? And so the aorta now is coming from the right ventricle instead of the left, and the pulmonary artery comes out of the left ventricle instead of the right. Things are just, they're a little wonky at where they should be. So what do you think the surgery is to fix it?
Flip-flop it?
Flip-flop it. You're exactly right. Okay, they just go back and flip it. Reposition of the vessels. But these kids can have significant cyanotic spells. Remember, a mixed deficit can give you some mixed cyanosis. So sometimes they're good, but maybe if we're stressing them out with a stress test like feeding or exercise, they can be cyanotic. It's a mixed defect, so you get a mixed bag, okay? So cyanosis with feeding or crying, they can have loud S2, a murmur may be present, and heart failure is present. So look for edema, tachypnea, and crackles in the lungs. Yeah?
In one of the videos that I was watching, it said that the use of prostaglandins is not popular, but used until surgery can happen. What does that do?
So prostaglandins work to keep things open often. So sometimes you need, like I said, sometimes you want to keep the duct open, or sometimes you need to keep blood communicating between things because you don't have the normal blood flow. And so that's what we give them for, until we give them prostaglandins to keep it open until we can take them to surgery and fix the defect.
How long can they?
Oh, they can stay for months.
Really?
But how do you keep, how does it regulate which one it keeps open?
Yeah.
Well, that's a medicine type question. I don't know the answer to that.
Ask Professor Bush.
Yeah, that's like a cardiac doctor kind of question. Yeah. So there's transposition of the great vessels. You can see they're just flipped the way they should be. And then we've got truncus arteriosus, which is another one, which is a mixed defect. And this is only one major artery leaves the heart and supplies blood to the pulmonary and systemic circulation. So that's a problem, right? So cyanosis with feedings or any bit of a stress test is, just think mixed defects give you a mixed bag of cyanosis, some and some not, right? And then you will always have the signs and symptoms of heart failure. Nasal flaring, grunting, restlessness, irritability, difficulty feeding, tachypnea, okay? And so we give them oxygen when they're cyanotic. Nutritional support, I'm going to talk to you about before we're done today, and then we have to go in and correct these anomalies. This is a big one. You can see the big trunk there, like a big nasty tree instead of being functional, right? Instead of having one here and one here, you got one big thing. Hypoplastic left heart syndrome. This is one that's pretty incompatible with life. Everything on the left side of the heart is underdeveloped and not working, okay? So that's a problem, right? So cyanosis, poor feeding, increased work of breathing, all of your heart failure signs, but these kids may just present in shock, okay? So you manage the shock, get them stabilized, so that may be pressors and fluids and oxygen, nutritional support, and then these kids need a heart transplant. When you see the picture, you'll understand why. Right? Left atrium pretty undeveloped, left ventricle very hypertrophied. So you can see that heart, it needs to come out and they need a new one. All right, this is where I escape to my other lecture. Hold on a minute. Life is just too busy. All right, this is the slide I wanted to talk about. When is it? 11, 10? All right. So a couple things just to really remember, overarching themes about congenital heart defects in children. The diagnostic testing is the same for kids and adults. We use the same vessels, wrist and groin. We do echoes, EKGs, stress tests may look a little different. We may not rerun them on a treadmill. We may be doing medication or other things. But we always have to think developmental level of the child. We use littler stickers and all of those things for that, right? Nutritional management is a big thing that we really have to consider in children with heart defects. What we know is that these children historically can have lower IQs and delayed growth and development. So we want to give them every chance we can to maximize their IQ, to maximize their growth and development. And a lot of that is nutritional, right? So we limit feeds to 20 minutes. And then we will put like a little tube down and feed the rest through that, because that is a stress test for an infant, and we don't want to stress the heart out. When we know there's a defect, we don't want to stress them out, okay? And the older child, we may do high-calorie shakes, puddings, supplements, things like that. If we're doing formula versus breastfeeding, yes, we always encourage breastfeeding, but we may increase calories by giving supplements as well, just to support that, okay? Medications are very similar as well. You'll find a lot of the same medications used. Airway management. Always make sure when your patients are having any increased work of breathing that you sit them up erectly to maximize expansion of the lungs. Oxygen, we're going to give some oxygen, and sometimes we're going to be a little more cautious in oxygen. If you think about, what do you guys know about giving oxygen to your chronic COPDers? Say it again.
Respiratory acidosis.
Right. So the same thing can happen to a kid who's got a chronic obstructive cardiac defect. I can't just flood them with oxygen. They can't utilize it, right? And if I've got a pulmonary increased blood flow problem, oxygen is going to vasodilate my pulmonary system. So not always is oxygen the lifesaver. You've got to know what you're treating when you're giving it, okay? Minimize crying. Crying is stressful to the body. So infants, we need them to be calm. That's why be calm was kind of one of those really important things when you're dealing with a TEP spell, okay? Infection prevention. These kids are at an increased risk for infections. If you think that kids get 12 to 15 viral infections every year, we've got to keep them safe. A lot of them are hospitalized for extended periods of time for surgery and things. So, we just have to really be thinking, vaccinations, keeping kids healthy, as well. There is a lot of education that peds nurses do when they work with Peds Cardiac. Can you imagine having a baby just on a good day, right? And it's a healthy baby. You still don't know what you're doing, right? Now you come home with a baby with a massive or major cardiac defect, right? So that's up to nursing to educate those parents to get them ready. You know, a lot of these kids go home on cardiac monitors, so you have to teach parents about monitoring. They go home with oxygen and oxygen tanks, and they go home with feeding tubes and things. So there's a ton of education we do, making sure they have the supplies they need. And then consider that a lot of this is diagnosed in the infant stage. So these are babies that are born decompensate in the delivery room, right? And so, you know, when we think of what we know now about the importance of bonding skin to skin, I mean, we leave those babies up there for hours between mom and dad's chests, right? Well, babies with CHD can't do that, okay? So we have to create other opportunities for them to form those emotional connections with their parents. And that's why if you see like things on social media, they're taking babies out of these, you know, bassinets on ventilators and putting them on the chest, because that bonding is critical for both people, right? And then a lot of them need social work referrals, right? They're going to need speech, like occupational therapy, physical therapy, lots of resources at home that we need to make sure they have available to them. All right, last couple things I'm gonna cover are heart failure and rheumatic heart disease and hypertension. And then we're going to take a break and get busy on an activity, okay? So heart failure. Heart failure looks pretty much the same in anybody, okay? So what happens in heart failure? The pump isn't contracting, right? So you know you've got your electrical heartbeat, and we've already kind of talked about electrically. There's a few things that can go wrong with kids, but a lot of those rhythms really are an adult thing, right? We can do AFib, we can do VFib, VTAC, sinus, Brady, sinus rhythm. We don't do a lot of other rhythms, but kids can go into heart failure just like adults. So think about heart failure, lungs filling with fluid. So you're gonna see a lot of the same things, right? Exercise intolerance, shortness of breath. I've got fluid in my lungs, of course I can't breathe. So I'm fatigued easier, I can't eat well, I get dizzy, I'm irritable, right? Kids even have a decreased urinary output. And then we look at their physical exam. We might see weight gain. In a child where we're not used to seeing edema, we may appreciate a weight gain before we appreciate edema. Tachycardia and tachypnea go hand in hand with CHD. Hypotension, hate hypotension. Pallor and cyanosis, very common. Sweating, do babies sweat? They shouldn't, okay? Cool, clammy, crackles in the lungs, all classic heart failure signs, right? So, why do kids go into heart failure? They usually have a congenital heart defect. Yeah.
Just to be super clear, kids shouldn't sweat, but they can. And if they do something like that's a bad
Infants
sign.
shouldn't sweat.
But
Kids can sweat.
But infants.
Infants shouldn't sweat. When you
At all.
see sweating in an infant,
But
you
what
better be
about,
looking
like,
at a CHD.
Right. So if we do see sweating, like sweating while feeding.
Sweating while feeding is an abnormal sign.
Right. That's
100%.
all. So I'm just making sure.
100%. Yep. Yep. All right. So, how do we manage heart failure? Positioning, right? Head of bed elevated. We give oxygen. Now, let's think about suctioning. Let's take this infant has RSV. Because nothing's easy with kids, right? They can't just have a heart defect. They have to get a normal kid's disease too. What do you think suctioning is to that infant? A stress test. Ultimate stress test, right? So yes, I may need to do suctioning, but I'm going to cluster my care and do short bursts of suctioning and be very cautious of how I'm impacting the cardiac status of my patient, right? So suctioning, that's a stress test. It's, you know, when you think about all the suctioning we do and that stimulates a cry in an infant, All these kids will be on a continuous cardiac monitor. They should all be inpatient in a cardiac unit. We may be giving digoxin. You guys should be familiar with that. Lots of nutritional support. And then clustering care. Do you guys cluster care with your adults at all? Where you kind of lump things and go in together? We're big on doing that with kids because we like to bother them as little as possible, okay? All right, so heart failure, you guys should be pretty familiar with. We've got to fix it with kids. Kids can't survive with heart failure for very long. So a lot of times it's a surgical repair to get the heart fixed. All right, we're going to talk about rheumatic heart fever. Acute rheumatic heart fever. How do we get it? Strep. We get a strep infection that goes like untreated successfully, and about 2 to 4 weeks later, we start with a rash, and we start with joint pain and a fever, and we get all kinds of symptoms that come out for the rheumatic. I don't know if you guys know this or not, but this is what rheumatic stands for. The R is for rash, the H is for heart problems, the E is for elevated inflammatory markers, so your ASO titer, your CRP and sed rate will all be high. It's an inflammatory response. You might have skin nodules. NCLEX loves to ask you about the skin nodules with rheumatic fever because it's what? Abnormal and unique. So don't forget the skin nodules. Arthritis and arthralgia, they have a lot of joint pain and swelling. They're fatigued, irritable, and then they can shake. So how do we diagnose this? Here's some manifestations.
Sorry. For the test, do we need to know what rheumatic, all those?
No. So the goals of treatment are to prevent progressive damage to the heart and its valves, okay? So we put them on bed rest the joints. We put them on antibiotics because we got to treat the strep infection, but we are going to check for strep again, okay? So we do throw culture and blood cultures on that kid. They're going to go on an antibiotic. They need steroids, and then they may need Haldol if they've got shaking too bad. And then anytime they go to the dentist moving forward, they get antibiotic prophylaxis. Rheumatic fever in children. Hypertension, I'm going to just talk to you about. I don't have a slide for it, but I want to talk to you a little bit about primary hypertension. How do we get primary hypertension in childhood?
Maybe genetic?
Oh, I like you.
Oh, thanks.
Probably the number one is hereditary, right? What are some other ways?
Diet.
So obesity, she's saying. If we're skinny, we don't have hypertension issues, do we?
Some people do.
Oh! If we've got hereditary, we do. But usually when you talk about diet, it's not an issue, right?
It can.
Well, no. I'm trying to make you see the difference.
Okay.
Time out. When you say diet, you're not talking about skinny people,
Oh.
But
Right?
but skinny people can, like if they have a
but that's hereditary.
no.
Are you
What I'm
asking
saying
me
is that a skinny person with a high metabolism can still eat nothing but foods that would give you hypertension and walk in with hypertension even though they're skinny.
No. What food's going to give you hypertension?
Sodium.
All foods that are bad for you. But if you're a skinny mini, think about a construction worker,
Okay.
a bricklayer that's skinny, but all he
We're
eats is
talking
roast
about
tofu.
children. We're talking about children. And hereditary and diet, it's obesity, people. It's not skinny kids. Skinny kids don't have hypertension unless it's hereditary. That's what I'm trying to say.
Okay.
You get that? It's the obese kids that have hypertension issues, not the skinny kids.
Gotcha.
Okay? If a skinny kid has a hypertension issue, it's hereditary.
Okay.
Now, if you're talking about the adult, maybe,
Right.
but even then, I'm going to question that. Okay? So let's go back to this. Hereditary, obesity. Anything else? Cause hypertension?
CHD.
Stress.
What about kidney?
What?
What about kidney disorder?
Oh, I like you again. Did you say that 2 times? An AKI, well, absolutely, or CKI. Kidneys regulate hypertension. Yeah. So, kids don't get a ton of hypertension. I'm not making you know the numbers of hypertension, but it's important to understand that they can have essential primary hypertension, okay? It's most often hereditary or diet related, okay? So those are kids that we would do all of the behavioral modification that we would do to an adult with. Diet, exercise, restrict fluids if we need to, okay? All of the same management. And then if it stays because I've got a hereditary problem, I go on medication, okay? All right. Let's take 10 minutes. I'm going to set up the assignment we're going to do.